Good afternoon, everyone. We're going to go ahead and get started today. My name is Lisa Nagel from the CAP Center here at NDSU School of Pharmacy. We are pleased to welcome you to our series on chronic disease with today's focus on diabetes. The webinar today is called Decoding Diabetes, Your Roadmap to Updated Standards. Here are a few housekeeping items for our webinar today. Please use the Q&A function for questions during the webinar, and we will address those at the end. During the webinar, we are going to have assessment questions, and we're going to utilize the chat function. So when you're putting in your answer, please select hosts and panelists to answer the question. This webinar will be recorded and available for viewing and continuing education. It will be placed on our website and our YouTube page in the next couple days. After it is ready, I will send out the information to all participants. So please feel free to share with your colleagues that aren't able to attend today. The CE information will also be provided at the end of the webinar, and I will be adding the next dates and Zoom registration links in the chat today for our chronic disease series that are upcoming. I would now like to introduce our expert speaker. Dr. Jennifer N. Clements is a clinical professor and director of pharmacy education with the University of South Carolina College of Pharmacy at the School of Medicine, Greenville campus. Dr. Clements earned her PharmD from Campbell University in 2006 and completed a primary care pharmacy practice residency in 2007 at the Ralph H. Johnson VA Medical Center in Charleston, South Carolina. Dr. Clements began her academic career in 2007, holding full-time faculty appointments with Shenandoah University before transitioning to the Presbyterian College School of Pharmacy, where she served as professor and director of postgraduate education. During her academic tenure, she developed pharmacy practice sites at a VAMC and rural health family medicine clinic with focus on chronic disease state management, specifically diabetes and obesity. From 2019 to 2022, Dr. Clements provided medication management for people with diabetes with an interprofessional practice model, where she oversaw inpatient diabetes management at Spartanburg Regional Healthcare System, over 1,000-bed center in the healthcare system, and chaired the Healthcare System's Diabetes Advisory Council. She has authored numerous publications and presentations related to diabetes and obesity pharmacotherapy. Dr. Clements is an active member of the American Association of Clinical Endocrinology, American Diabetes Association, Association of Diabetes Care and Education Specialists, American Society of Health System Pharmacists, and American College of Clinical Pharmacy. She is a board-certified pharmacotherapy specialist and board-certified ambulatory care pharmacist, as well as holding certification in diabetes care, education, and advanced diabetes management. We are so lucky to have Dr. Clements with us today. With that, please take it away.
Well, first, thank you for that introduction, and also thank you for the invitation to speak on the 2024 standards of care in diabetes provided by the American Diabetes Association. With that introduction, it makes it easier where I can bypass introducing myself to you. And again, I appreciate the bio and the review. Here are my disclosures for this presentation. And for the learning objectives, what I hope that you're able to do at the end of this is review key updates to the 2024 standards in diabetes, evaluate the impactful changes in the new standards to 2022 and 2023 publications, as well as apply recommendations to pharmacy practice. Here's a list of abbreviations you can refer to throughout the presentation. And again, use the chat function to enter in for this first question, what is your primary practice setting? And make sure you share it with the host and the panelists. And this just gives me an idea of who's in the audience today. And so already I see some answers for ambulatory care and health system hospital. I do have some others, so there are some maybe students and residents that are joining us today. But right now, the answers are all between A, B, and C pretty equally in terms of primary practice setting. Now, another question that I have for you just to kind of warm up on today's topic is, how do you stay up to date on the standards of care? So do you not read them so you don't remain up to date? You read only the summary. You read only the sections relevant to your practice. You read all the sections. And the other option is you review them throughout the year. And already I see just kind of a little bit more answers for summary and then all sections of the standards. Some may not be up to date or read them every year. And then, of course, I see now some answers as far as reviewing them throughout the year. So before I get into the standards, I just want to review what we are talking about today, and that is diabetes, where it is a complex condition in which we do need continuous medical care that requires risk reduction strategies so that we're addressing not only the glucose levels, but now we know there's evidence to address cardiorenal risk, so we prevent acute and chronic complications. Now, of course, this can be achieved in a team-based atmosphere so that there's a range of interventions from multiple healthcare professionals and strategies in order to improve outcomes. The magnitude of diabetes is great. We know we see a lot of individuals with this chronic condition in practice. So as a quick review, these are the statistics related to the current prevalence of diabetes, where you see 38.4 million living with that. And you can also see on the flip side with pre-diabetes, so 97.6 million. And this just, again, gives you kind of the incidence or the prevalence too in terms of diabetes and what we're talking about. I don't have information on obesity while I'll talk about weight management later, but I think we do need to draw our attention to know that about 50% of adults will be living with obesity, and that is a BMI equal to or above 30 in just 6 years. So that's predicted prevalence by the year 2030. And I mention this because we know diabetes and obesity are quite common among people we encounter in clinical practice. Now, getting right into the standards, I wanted to provide you what their definitions are for the level of evidence. You'll see this as far as A, B, C, or E, obviously ranging A with the strongest type of evidence based on the methodology of these publications, all the way down to E, which is expert opinion. Now, probably about, I would say 5 or even 6 years ago, the standards became a living document. So they will be updated throughout the year based on evidence that comes out. And you can access these through the American Diabetes Association. You can access the whole document or each section, depending on your preference. You can also download the app. It's free on your phone, and it will update if there are any sort of revisions made throughout the year. With me today, too, I have the 2024 standards printed, and then also I pulled the 2023 ones. So I'm kind of ready in case you do have any questions about those, and you could get these print copies through the American Diabetes Association. But now the standards have many sections in it, so 17 different sections that are all, relevant to maybe what you're doing on a daily basis. But it does cover a wide range because they do want to provide information for generalists all the way to the specialist, as well as different disciplines, so dietitians, pharmacists, etc. So, of course, you can pull each of these as they apply. And I had to think for myself, what would be the best way to provide an update to pharmacists? And I decided to kind of narrow it down into 5 different categories. But before I go over those 5 categories for the updates in this presentation, I do want to draw your attention to some principles that are outlined in the standards. And again, you can find these standards through the American Diabetes Association app. You could search through it through the store, just by simply typing in American Diabetes Association or even standards of care, and you'll probably see the symbol for the organization. Now, these person-centered decision cycles kind of guide you from start to finish when you encounter a person with diabetes. And I really think these reflect the pharmacist patient care process that we teach pharmacy students, as well as then hope to carry out once somebody graduates and they get embedded into clinical practice. But if you look at the little box for you, these are the principles to carry forward by using the appropriate language, like a person with diabetes, incorporating diabetes self-management, education, and support, making sure it's person-centered, but addressing other things like weight management, monitoring, their behaviors around medication taking, adherence, and persistence. And then lastly, what you'll see when we get to pharmacotherapy is addressing therapeutic inertia. So always reassessing and modifying that treatment plan. So let's get ready for the top 5 updates. And again, this was extremely hard because one could say we should go over all of the information in all the sections, but some of it, again, may not apply to what you do on a daily basis. So I tried my best to kind of narrow it down to these top 5. And I'm going to start with screening and medical evaluation. The reason I chose to start with this is because as pharmacists, we can often encourage within our team certain laboratory tests be done to see if they have maybe a certain type of diabetes, or they may have some comorbid conditions, and we need to be very mindful, and it could help us do some risk stratification. So I'm going to start with screening for type 1 diabetes. And as you can see, there's probably 3 different recommendations to be aware of, because last year in the 2023 and carrying over this year, we have some guidance on what are the preferred 4 autoantibodies that should be done so that we can start screening and looking at the stages for type 1 diabetes. The ADA outlines 3 different stages. So stage 1 all the way to stage 3. So kind of asymptomatic all the way to type 1 diabetes and having that diagnosis. But we know that there are certain autoantibodies that could definitely be drawn in order to make that diagnosis. Of course, there's now also therapy that can be recommended to even delay the development of clinical type 1 diabetes. So this is really an area of interest because some providers, like in primary care or even pediatricians, may not be aware of these screenings. And this is where we could have an impact by just making those recommendations. So one question I do have for you related to the screenings is, do you know which medication can actually delay the onset of symptomatic type 1 diabetes, which is stage 3, and can be considered in selected individuals that are 8 years or older with stage 2 type 1 diabetes? And you see on here lots of different maybe monoclonal antibodies as well as immunosuppressants. And already I see a lot of answers for E. So teplizumab is a new medication that is available. And some of these you can see A through D are existing medications that have been around for other disease states. And so everybody that added an answer in the chat chose E, and that is correct. So I just wanted to draw your attention as we talk about screening of type 1, we have a recommendation to utilize teplizumab as an infusion for the onset of symptomatic type 1. And this, of course, would require going to a specialized clinic. It could be very costly. It may be only done at certain healthcare institutions. There's a lot of monitoring with it. So, of course, we've got to make sure that those involved are adequately trained and educated. So it's just drawing your attention, if you were not aware of that, to something new from the 2023 and carrying over to 2024. Now, the next thing I wanted to talk about is liver disease. And this is, I believe, going to be a huge topic over the next 2 to 3 years. We know that there's ongoing evidence with pharmacotherapy, but what everybody's talking about is screening. So how can that be done? And within the standards, there's actually 4 different recommendations that you really can start to look at someone, like if they have type 2, obesity, cardiovascular risk factors, and start to screen for fibrosis, even if they have normal liver function tests. And we know that's probably the starting point a lot of times. But from there, I think we need to take these recommendations for screening and start to have the conversation of how we can make it fluid and easy in our electronic record systems so we can gather information quickly or have it calculate somebody's risk of fibrosis so we know what's the next step. Do we progress in terms of a type of biomarker, or do we make the referral to a gastroenterologist or someone that specializes in the liver alone? So that's where these recommendations could come into play. One of the biggest updates involves bone health. And I think, again, as pharmacists, we know we have involvement in the community setting with maybe some services, maybe some tables, right? Educating the individuals. In ambulatory care, we talk to individuals and ensure they're getting proper bone health through supplements or the right medications. But the ADA has added in these strong levels of recommendations regarding assessing someone's risk, particularly those of the older population, and then promoting certain types of screenings, like with our DEXA, in those higher risk individuals or those that are younger with multiple risk factors. They also provide that should be done every 2 to 3 years. What they further go on to say with the strong level of evidence is that when we look at pharmacotherapy, we should evaluate the effect it may have or the impact on bone health. So not only that it will lower glucose, but is it safe for bones? And we know TZDs, as an example, are ones that have kind of fallen out of practice, but we know still used, however, have been shown to increase fracture risk. But recommendations with a lower level of evidence regarding or in regards involves those as far as individualizing glycemic management to reduce the risk of falls and fractures and prioritizing the use of certain medications that are associated with a lower risk of hypoglycemia. I don't think this is to say it's not important, because we know we may avoid sulfonylureas or lower the dose of insulin in individuals to avoid falls because we're trying to avoid hypoglycemia. And then for those practicing maybe in a cardiology clinic, there's some updates as far as monitoring the BMP for those screening in terms of stage C heart failure, as well as those that are asymptomatic with an abnormal value and then proceeding with an echo. They've also provided more information regarding peripheral arterial disease and the testing, as well as those with diabetes for a longer period of time in which they should also be screened for peripheral arterial disease. So these specific recommendations all fall under Section 10, which involved cardiovascular disease. So I know that was fairly quick, but we're going to move on to health and well-being. And so just a quick question, which immunization from this list is highly recommended for adults with diabetes? So is it hepatitis A, HPV, meningococcal, or pneumococcal? And already a lot of people are putting in choices of D, which would be correct. And I throw that out there because every year within the standards, one of the tables in Section 4 gets updated. And so in 2024, you can find information related to these highly recommended immunizations for adults with diabetes. This then leads me to just mention that RSV has been added to that table. We know this has been a hot topic since it got its approval, and individuals are asking about it. So the specific table indicates that it would be for older adults that's 60 years or older with diabetes, provided as a single dose injection or immunization. The other thing I wanted to make you aware of is diabetes distress. this has been something added and highlighted in which not only individuals with diabetes, but caregivers and family members should be screened for distress at least annually and perhaps more frequently depending on their treatment if they're being met or they develop complications. And so I just found this interesting because I think it just puts a little bit more emphasis on their own health and well-being so we can address that properly, but also on a consistent and frequent basis if needed. With that, when we think about diabetes distress, there have been some updates in terms of the recommendations for anxiety and depression. What's interesting about recommendation 5.40 is that it used to say screen for anxiety symptoms, but now they've added the fear of hypoglycemia as well as diabetes related worries. And that's interesting because we should be looking at anxiety and how one may be doing or any related symptoms if they're stressed or concerned about their diabetes, as well as have a fear of hypoglycemia. In addition, with depression, they say an annual screening, but obviously that could be more frequently for those that have a self-reported history of depression. I think that we need to still refer to validated questionnaires when we look at depression in terms of documenting that in the chart to then make determination of the frequency, because self-reported history, could vary across the board. So I think still, even though this is a level B recommendation, this validated questionnaires can be very useful. What's also been added is referrals to qualified professionals. I won't read all of these, but these are related to, health and well-being, anxiety and depression. And so it's important that perhaps even in where you practice, you incorporate some of these. It could be, a checklist or a reminder on a computer that if you see somebody that meets one of these, they could be referred on to someone else so they can get additional counseling or guidance and assistance to help them with their anxiety, depression, or even diabetes distress. And then my last question in this particular update is, should people with diabetes be counseled on sleep promoting routines and habits? So do you think that would be yes, no, or maybe? And so in the 2023 standards, there was a great chart or illustration that has also been incorporated in this year's publication. And it really did emphasize sleep because we know we probably don't talk about sleep enough with any individual. We know the impact it can have on multiple comorbid conditions, especially like diabetes. But this particular statement is yes. So there has been added in there in terms of a recommendation to counsel all people with diabetes about sleep promoting habits and routines, as that could have an impact on their glycemic management. So you can refer to that particular statement in section 5, where most of these recommendations are, as well as other ones I went over in the first update. So now we're kind of in that part of kind of number 3 for our updates. And this is where we're going to shift and start to look at hypoglycemia as well as glucagon. I will say that some of these sections even got an update as far as the title that the section used to be called. So if you're looking for something specific you've seen in the past, it may have gotten renamed. So with this, let's start with kind of our first case. And we have a 72-year-old man on insulin due to type 2 diabetes, and he was found unresponsive by his wife at home. He wasn't feeling well, even refused to eat dinner. And she calls, let's say, the ambulance. They come, check his glucose, and it's 30. This individual is unresponsive, but not having any signs of a seizure. So with that question, for that case scenario, let's look at this question. So which choice reflects the most appropriate initial action? So you can go ahead and put in your answers and we'll revisit this once I go over some information and I can see if it changes. So would you give glucagon or oral glucose gel, transport the individual to the ER, or wait for further assessment for someone that's more qualified? And already a lot of people are putting in A as the choice for this. So a couple of B's now have been thrown in there. So let's see if that changes. One of the updates for hypoglycemia in that section is really the emphasis on de-intensifying regimens. So with our pharmacotherapy, that means backing down on it so we lower their hypoglycemia risk. The other choice would be to switch. So switching those agents to something else. What we also want to be aware of is that when there's harm or the burden of treatment, that basically that risk outweighs the benefit, we can also de-intensify, because we know we don't have to be as stringent as we may want to be. And that could relate to one of the many risk factors or considerations we take into account when trying to determine one's A1C goal, because it's not always less than 7%. So I'm just curious, before I go over the recommendations with glucagon from the 2024 standards, how often do you recommend glucagon to people with diabetes on insulin? Is it never, rarely, sometimes, often, or always? And already I see really rarely to sometimes. I do have one often. But right now we kind of have maybe an even balance between rarely and sometimes, with at least one or two never or oftens thrown in there. But you can see just from this group, there's no one putting in there that they always recommend glucagon for people with diabetes that are on insulin therapy. And that's probably one of the biggest changes in the guidelines or the standards is from Section 6. I think the statement that sticks out is that it says glucagon should be prescribed for all individuals taking insulin or at risk of hypoglycemia. Again, I think when we look at these recommendations, we have to look at the level of evidence, and this is an expert opinion. So with that, if you give glucagon, people should know how to use it. So that requires education. They should know where it's stored. And now we have ready-to-use glucagon, which has been around for probably about 4 years now. And this is preferred because it's easier to use and administer in this high stress situation. We don't want to have to worry about reconstituting. We're able to use maybe the nasal powder or the subcutaneous one, the pre-filled pen, the auto-injector, whichever is preferred to get that rapid correction in hypoglycemia. So I put the generic names on here for you, the different forms, as well as the dosing. However, publications have shown that this is underutilized in terms of glucagon. That's the type of medication it is. It's probably underutilized because we don't recommend it enough, but also it does have a high cost associated with it. So now I'm curious, if we go back to this scenario, does anything change for you in terms of what you would do with this individual? So answer again, if you would do glucagon, oral glucose gel, send them to the ER, or wait for somebody else more qualified to come. And I can see already based on the answers that, your recommendation or your next step in this scenario would not change. However, what you now know is that perhaps we should be promoting glucagon more often for those on insulin or at high risk of hypoglycemia. So this would be the correct answer just because he is unresponsive. We'd want to get it up. And if you're in a healthcare system, perhaps you could even talk to EMS about using something that's easier, like the auto injector, given that they don't have to reconstitute it. Based on my prior experience, I can tell you that even going down that route, the reconstitution prep kit or emergency kit was still cheaper by a couple $100 than some of these newer products. And I think that will continue to be the limitation unless that level of evidence changes from an E to something higher. The other thing I wanted to recommend, because technology is always a hot topic and there may be other presentations you can participate in regarding technology, is that CGM is beneficial and recommended for those at high risk of hypoglycemia. So this really should be offered to people with diabetes, and they've kind of expanded that. We see the strong level of evidence with real-time CGMs and also intermittent scanned CGMs, where we should be recommending these for people that are on multiple daily injections or their pumps. I think too, we've opened the door because of evidence for those just on basal insulin. It doesn't have to be basal plus bolus, in which we can use a CGM. So just know that really, since CGMs have become available, a lot has changed, even on a state level for coverage. We don't have to do as much documentation or ensure they're checking 4 times a day, maybe even multiple medications. You know, we have a little bit more flexibility because we've seen the evidence come out. Now, that was a quick review of hypoglycemia, as well as technology briefly. So our continuous glucose monitors. I didn't cover so much with pumps. There wasn't a whole lot of updates regarding that bit of technology. And now we're going to shift into weight management, because this was another area that got an update given new approvals for pharmacotherapy. One thing I wanted to draw your attention to is there's no specific recommendation. However, the standards snuck in about measurements of weight. So again, not a specific recommendation, but it's interesting to see that they still say BMI, but we also need to add in or evaluate other measures that look at body fat distribution. So together, we need to look at these obesity-related measures at least on an annual basis whenever we're considering treatment. And I just found that interesting because we know that BMI is easy to calculate and can be blown into the EHR. However, we're having statements, you know, that have gone over long time about, is BMI a reliable measurement or not? So it's kind of a combination with what they mentioned and included this year. What has carried over is a person-centered approach when it comes to weight management. So really, they emphasize and highlight that not every person will be treated the same. And so we really need to consider what is the risk, efficacy, and cost of each option. And they are pretty, you know, they include a lot, as you'll see on one of these slides upcoming, you know, that there's a lot of different options. They don't provide recommendations with levels of evidence for all of these, like medical devices, for instance. But of course, they do provide recommendations for nutritional, particularly because we're talking about people with diabetes. They also provide level of evidence for the weight loss medications. So when I say that, ones that have the indication for weight management, then they do provide as far as metabolic or bariatric surgery based on populations and what their BMI is. So just quickly, before we go over the updates, you know, which class listed here can promote weight loss? So is it biguanides like metformin, DPP-4 inhibitors, GLP-1 receptor agonists, sulfonylureas, or TZDs? And already I see, you know, people selecting the correct answer of GLP-1 receptor agonists, and probably many individuals are familiar with this class given what we saw in trials with diabetes and the weight loss that came from that is like more bang for their buck. But now we have medications specifically approved from that class solely for weight management. Now, drawing your attention to these recommendations, what's important is to keep in mind that now you can have sustained loss. So the greater the weight loss, the greater the benefit to the individual. That's probably because of drugs like semaglutide and tirzepatide showing, you know, 15 up to 21% reduction. And we're seeing secondary outcomes of percent of individuals losing 10 or even 20%. The other thing that's been updated is 8.17. So in those with diabetes, and if they have their weight as overweight or classified as obesity, the language has been changed. Preferred pharmacotherapy is a GLP-1 receptor agonist or the dual incretin, which would be tirzepatide. So often it's going to be semaglutide or tirzepatide because both of those have what's classified as very high efficacy for weight loss. But one thing they've also added this year is therapeutic inertia for weight management, that we always need to be reevaluating and intensifying treatment based on those follow-ups. Here are the other options mentioned in this particular section, which is section 8. Again, not all of them have specific recommendations, but I just wanted to be comprehensive and let you know that in that section, they do mention these 5 different areas in terms of weight loss. Now, while I'm talking about pharmacotherapy, I wanted to mention that the standards now say it's very important that we do intensification or we even prioritize our therapy for glycemic management. So these next couple of slides are really no change from 2023 standards. I just wanted to show it briefly and draw your attention to it to be mindful that we still need to do a better job addressing therapeutic inertia and choosing therapy based on someone's cardiorenal risk, as well as looking at glucose management and weight management. So again, this has not changed, where we promote healthy lifestyle behaviors, diabetes self-management, education, and support, and address social determinants of health. From that, you kind of have 2 different pathways, and using my cursor, the first pathway is cardiorenal risk reduction, where if they have the presence of these 4 conditions, it drives our therapy. Whereas if we choose glycemic weight management, glycemic and weight management, then we kind of will choose based on efficacy of the drug. So to kind of go through these slides quickly, because there's been no change, I wanted to just introduce a case first. And this is an individual that's 45 years of age, a non-Hispanic Black woman with stage 4 chronic kidney disease. eGFR is 25. So her history includes hypertension, type 2 diabetes, currently on metformin, HCTZ, and losartan. Blood pressure is 128/78, and weight has been stable. Current A1C is 7.1%, and the urinary albumin to creatinine ratio is above 300, which is unchanged from last year. So which medication would be the most appropriate option for this individual today? And for the sake of time, just think about it, because we're going to come back to it. You see an SGLT2 inhibitor, a GLP-1 receptor agonist, a DPP-4 inhibitor, and then our dual incretin. So again, these slides, no change from last year, but I do want to draw your attention that the main point is when we look at the presence of one of these cardiorenal complications in someone with type 2 diabetes, so of the adult population, we really need to choose the class and then the specific agent that has the proven benefit. So ASCVD, we have certain GLP-1s and receptor agonists and SGLT2 inhibitors, which is the same for high-risk ASCVD, more so that they haven't had an event, but they have a certain age, so 55 and older, with 2 risk factors or more, and those risk factors are provided for you. If they have heart failure, it's, current or prior symptoms, regardless of if it's HFrEF or HFpEF, you choose an SGLT2 inhibitor. With chronic kidney disease, the information has not changed either in terms of eGFR, albuminuria, and how chronic kidney disease is defined. But what has kind of slightly been modified is that they need to be on a maximum tolerated ACE inhibitor or ARB before choosing probably what is the top agent or class, an SGLT2 inhibitor, or a GLP-1 receptor agonist that has cardiovascular benefit And the reason you would select that class is because they can't be on an SGLT2 inhibitor for whatever reason, like a contraindication or intolerance. Now, if they don't have cardiorenal complications, we can simply focus on glycemic management, and this hasn't changed as well. Metformin still recommended. Combination therapy is great for efficacy. We want to avoid hypoglycemia, as we previously talked about, but you really want to look at the higher efficacy medications. If you specifically focused on this slide, as well as weight management, you would see that semaglutide and tirzepatide rise to the top as very high efficacy medications for glycemic management as well as weight management. And of course, what they emphasize in both of those tracks is that we need to achieve and maintain whatever goal we set for the individual, knowing there's many options to do that. So to come back, what would you choose for that individual with stage 4 chronic kidney disease, who's also on metformin, HCTZ, and an ARB? We can say that's at maximum tolerated dose, with an unchanged urinary albumin to creatinine ratio. And of course, a lot of people are choosing A, which is the correct answer. You know, we want to be able to utilize these SGLT2 inhibitors all the way now to an eGFR of 20. And this person had 25, so of course we would want to do that. You may see more evidence come out soon with semaglutide based on the FLOW study that was stopped early. And then we're waiting for some cardiovascular data with tirzepatide, but we do have maybe some preliminary information to show it could benefit and improve renal outcomes. So now there's some other recommendations for medications, and these are related to cardiovascular risk. But quickly, if someone has type 2 diabetes and hypertension, what's the desired blood pressure goal? So is it less than 120 over 80, less than 130 over 80, less than 135 over 85, or less than 140 over 90? And based on what people are putting in, a majority are selecting B. And that is something I wanted to highlight because there have been some changes, even going back from 2022, that finally we're all on the same page that the goal is less than 130 over 80 for those with diabetes and having hypertension. So on this slide, while I won't read anything to you, you see the bolded information is highlighted. That is the change for screening and diagnosis of hypertension from 2022 all the way to 2024. And I thought this would be good so that you just see the language change and even also how things are defined, like elevated blood pressure, and then also the definition of hypertension, which really varies from what I was taught when I was a pharmacy student. This next slide goes over that the treatment goals have also changed. So you see kind of the simplification of the language all the way from 2022 to where we are now, that the goal is less than 130 over 80 if safely obtained. So that means we look at our individual and think about the risk of hypotension. Now, down in the text box, what's also interesting is that for some reason, the standards had to update and really include the language of when we monitor renal parameters as well as potassium after starting certain therapeutic medications like ACE inhibitors and ARBs, and that should be done on an annual basis. Moving on to lipid management briefly, this information focuses on primary prevention from 2022 to 2024. And I've bolded the changes for you, but note that even some of the level of evidence changed from last year to this year because of perhaps a reevaluation from the subcommittees and looking at the evidence or new evidence that was available. I always found this interesting last year that now we're back to goals for LDL, which I often wonder if that's difficult for primary care providers to get back in the habit of looking at. When we had that, then we focused on percent, and now we're back to goals. But one thing interesting from the 2024 is that they have this emphasis for people that are intolerant on statin therapy, that really we should be recommending bempedoic acid, I always mess up on the name of that medication, for reducing cardiovascular events as an alternative plan. So I found this just interesting that now we're seeing recommendations on those intolerant to statins and what could be some alternative options for them. Secondary prevention had an update in 2023, which is carried over for this year. And again, it's where we see that LDL goal be about less than 55 milligrams per deciliter as the target, with a very large reduction from baseline. We also may have some additional options thrown in there because we know not everybody could tolerate the maximum or high intensity statin that's recommended in this population. Similarly to primary prevention, we do see a recommendation this year, although the levels of evidence may vary, for these alternative therapies for those that have ASCVD and need to be on a statin but can't quite tolerate it. So again, you have some alternative options you can go to. And lastly, I just wanted to mention that there is a recommendation for SGLT2 inhibitors for heart failure, but when you get into section 10, they put in parentheses the SGLT1/2 inhibitor that has been approved for heart failure. So tagliflozin was approved. Its original indication for type 1 diabetes could not make it through the FDA, but then based on cardiovascular data, it did get the approval to reduce the risk of worsening heart failure and cardiovascular death. So this drug is just unique because it hits on 1 and 2 as far as that co-transporter. And now I have some bonus information that I just want to highlight briefly before I go into honorable mentions. So this scenario is an individual that's 49 years of age and was admitted to the hospital for DKA. They have a 14-year history of type 1 diabetes, and they're using an automated insulin pump with a CGM. So now that their condition is stable, the resident wants to put in correctional with bolus insulin that would be given 4 times a day, and then also prandial, so with their meals. And this is during the transition of IV to sub-Q. Now, just reflect on these statements as we'll revisit them, but really, what is the best or most appropriate action for this individual? That we change the bolus insulin to every 1 to 2 hours. We recommend basal insulin to prevent ketoacidosis. We restart their technology 2 hours after the infusion, or we verify these 2 orders for prandial and correctional insulin. So the reason I say this is bonus is because I could spend a whole hour on, really diabetes care in the hospital, because I think we're seeing more pharmacists become involved in diabetes care in the hospital and really doing what is now a term, glycemic stewardship. So what we see in this particular standard, which is standard 16, is some kind of revisions or expansion on recommendations related to protocols in various areas, the initiation or intensification of insulin, even the goals. So there has been a little slight change in the goals, but generally they're 140 to 180. But the biggest update has been continuation of diabetes technology. We know more people could come in on this, and you need to have protocols in place to ensure the safe use. The other recommendation does have to deal with being able to continue SGLT2 inhibitors in the hospital once someone is stabilized, if they were admitted for acute illness, or maybe they had some hemodynamic changes and now they're stable. As long as there's no contraindications, you can continue that. But the general management of diabetes in the hospital has not changed. We still prefer insulin, and depending on their, kind of eating status, their nutritional intake, It could vary, but we do want to use basal insulin plus the bolus. The bolus is what may differ depending on their nutritional intake. The other not recommendations, but additional information in this section do deal with the American Society of Anesthesiologists coming out to make recommendations on GLP-1 receptor agonists and holding them prior to surgery. The inclusion of maybe low-dose basal insulin for IV insulin infusions, as well as nurse-driven protocol when it comes to the management of DKA and HH&S. So one thing I mentioned is that the management in the hospital has not changed. So if we go back to this, what do we think would be the best option? Changing that bolus insulin to every 1 to 2 hours, initiating basal insulin, or restarting the technology after we start the infusion, or just verifying these 2 orders because they're good to go. And already I see out of majority of the answers, I'm getting B as something people would do. I see a couple of C's in there as well. And we have to think, you know, this is an individual with type 1. We go back to pathophysiology. They don't make any insulin. So it's going to be very important we have basal insulin on board for anybody that has type 1 diabetes, just because that's their background insulin. We want to prevent them going back into DKA. As far as C being the other choice that people would select, we can start technology before we discontinue the infusion. So allowing them to reactivate their pump and their sensor, and doing that before we stop the infusion will be key. And so we can ensure the safe transition with that. Now, these are honorable mentions there for you. I won't go over them, but I think, of course, you can refer to Section 1 with cost information. Section 5 highlights that it's not 4 critical times for education and support. There's now 5 critical times. There's information on older adults, and that would be Section 13. And so refer to that if you work with that population. And then pediatrics would be 14, where there have been, you know, several changes, maybe additions or revisions to the recommendations and other information. And so my final thoughts, this is something for you to reflect on. There's a lot. I mean, there's just simply a lot in the standards. And so you have to really think, like, what changes really impact what you do on a daily basis as far as your practice as well as your site. And really think too, what recommendations that you learned about today or even read about, if you stay up to date on the standards, can you start to implement tomorrow? So overall, as far as conclusions, one thing I'll say is there's major and minor updates every year, and that's no different for the 2024 standards. Several recommendations do apply to what we are capable of doing and have the kind of scope to do in pharmacy practice, and we can easily implement and even promote some of these recommendations tomorrow, I think, when we encounter a certain population or a specific individual that's living with diabetes. And lastly, if going back to the beginning of my presentation, I would say always think back to those principles of care, because we do want to use this same language in addressing them, promoting education and support, promoting medication taking behaviors, as well as addressing therapeutic inertia so we can help them achieve the goals that have been set, as we know that optimizes their care. So I really appreciate your time and attention. Questions are always free at no charge to you, and we have about 6 minutes to do that. But again, thank you for attending, listening, as well as participating in the chat regarding this presentation.
Well, thank you, Dr. Clements. That was an excellent presentation. I did learn a lot. Do have a couple questions, and I'm actually going to share my screen now with the CE code while we have a question. So I'm going to quick share my screen. So there is the CE code for our attendees. And one of the questions, are there specific guidelines or recommendations for incorporating telehealth consultations or remote patient monitoring in diabetes management plans?
Yeah, so that's a great question. Last year in the 2023 standards, they did update and kind of be more inclusive of telehealth, telemedicine. And so what I do is I always keep the whole publication with me. I even have it saved on my computer. And there are recommendations to kind of guide someone because we know people are doing this, particularly from the pandemic. And we know that if you have frequent follow-up or you do it well, and you're mindful of who would benefit from these types of services, that it can be done as recommended in the standards. Another thing to think about too is with remote patient monitoring, people are considering this in terms of maybe CGM, so the continuous glucose monitors, where they're able to pull the information kind of remotely and then provide guidance as long as the patient or the individual with diabetes provides them with details regarding maybe what they've eaten over the past 24 hours or if they kept a journal, but particularly with their medications, because often as the pharmacist will be guiding them on pharmacotherapy.
Great. Well, let me double check here. Maybe one more question I think we have time for. With rising medication costs, do the 2024 standards offer any guidance on addressing affordability concerns or navigating insurance coverage for diabetes medication?
Yeah, so if you go to section 1, they do have specific information now. It's not a recommendation, probably because we know that's going to vary depending on where you practice and the types of coverage you may see with your patient population. But we know that the cost of insulin and medications in general is always a concern and something we're going to always have to evaluate and find what is the cost-effective choice. But they do now provide a subsection related to that because we know that the pricing of insulin has probably been updated, given some Medicare and working with manufacturers to make it about $35. And so you could always go to that to see. One thing I'll mention as I look at this question too, if you go to section 9, where all the pharmacotherapy is mentioned for insulin, so type 1, and then all the pharmacotherapy for type 2 as well, they do have nice tables that summarize all the medications and insulins. It would include cost there as well. So we use different resources as pharmacists, but that's another quick and easy way.
Great. Looks like we have one more. Jardiance is now generic in Canada. Do you know if it will be soon generic in the United States?
I'll be honest, I don't know when it would be generic, given when it was approved, probably, I think in 2013, but I would assume that that is always something that we may anticipate here in the United States. It's just probably a matter of when, but that may be a question for the reps with that particular product.
Sure. Okay. Well, it looks like we've gone through all of our questions. I just want to thank you again for all the attendees. You will receive an email once the video is ready, link to the video as well as CE information and the slide set, as well as some more CAP Center information. And thank you, Dr. Clements, for your expertise today. That was really well done. We appreciate it.
Thank you.
Thank you and take care. Bye.
Bye.